Welcome back, everyone. It is your 1 o'clock session for track one, and you are in for a treat today. So today we have Dr. Armin Afshar and Dr. Timothy Murray. They're going to be speaking on your eye after treatment. So Dr. Murray couldn't be with us here today, but he's got a recording. And what's going to happen is we're going to show the recording from Dr. Murray, and then we're going to open it up for questions, which Dr. Afshar will answer, and he will make some talking points on Dr. Murray's presentation and some notes of his own. And so let me introduce you to who Dr. Murray is. Dr. Murray's focuses on founding the private ocular oncology and retina center. It was related to his ongoing pursuit of excellence in clinical care, particularly targeted on advanced imaging and treatment technologies. Dr. Murray's Ocular Oncology and Retina Center continues to improve international, national, and regional care for patients with life and sight threatening complex eye disease. And Dr. Armin Afshar is an ophthalmologist who specializes in treatment eye tumors and disorders of the retina and vitreous, which is the gel-like substance at the back of your eye. Has the special expertise in managing ocular surface tumors and of the conjunctiva and cornea, as well as the intraocular tumors involving the iris, ciliary body, choroid, retina, vitreous, and optic nerve. I'm going to give myself an A plus for effort on the vocabulary. So let's begin with Dr. Murray's presentation. And again, start putting your questions into the chat so that Dr. Afshar can answer those as we go. Let's get started.
Hello, I'm Dr. Timothy Murray from the Miami Ocular Oncology and Retina Service in Miami, Florida. It's a pleasure to talk with you all today, and I'm going to focus on some of the advances from a patient's perspective on what to expect after radiation treatment for uveal melanoma. The most common complication associated with radiation treatment of your cilio or choroidal melanoma is something called radiation retinopathy. Radiation retinopathy or optic neuropathy are damage that occurs to the visual structure of the eye that can limit the vision for you as a patient. It appears that this can be dose dependent, so the closer the tumor is to the optic nerve or the macula, the more likely this is to happen. And so we call that a dose dependent treatment compromise to those tissues. What's interesting is that we used to think that this was a very delayed event, that it didn't occur when the treatment happened, but it occurred later. As we've become more sophisticated to be able to look at eyes after radiation treatment, we're recognizing that this complication may occur much earlier than was recognized previously. And in the past, there really was no treatment for this. So there's been a huge advance and evolution in treatment over the last 10 years. And that's what I'm going to talk about today and talk about what you want to do as a patient with this condition. So a very famous clinical trial called the Collaborative Ocular Melanoma Study looked at photographs of patients before and after they were treated with radiation therapy. And they showed that initially at 1 year, only 10% of patients had evidence of a change. By 2 years, about 24%, and by 5 years, about 50%. So I kind of made it the rule of 10 per year. There's been a huge improvement in our technology called optical coherence tomography. And that literally allows us to see the retina at virtually a microscopic level. That advance now lets us look at the macula in a very unique way. And it's critically important that your eye be looked at with that treatment approach and that imaging study. And in that study, by 1 year, instead of 10% of patients that may have shown evidence of the radiation retinopathy or optic neuropathy, it was almost 80%. So we realized that this is very common. Now, we used to treat eyes with melanoma with a nucleation where the eye was removed, and virtually that does not happen any longer for melanoma patients. Melanoma patients are routinely treated with radiation therapy. That can be a patch of radiation called brachytherapy or plaque radiotherapy, or it can be a beam of radiation called charged particle radiotherapy. At our institution, we use plaque brachytherapy, and the dose we use is set to treat the tumor to a specific level for all layers of the tumor. And for us, we call that 85 gray to the tumor apex. It's important to know that you have to have a good margin, so it's very critical to know that the plaque sits around the tumor. And then it's very important to know that this is not about a single treatment. This is about treating the tumor and then managing your eye and you as the patient forever. So it's important to know that your visits with the ocular oncologist, such as myself, will be ongoing. So the collaborative ocular melanoma study used a very standardized plaque, and the advantage for that plaque was it was standardized. We use that 2 mm treatment margin. We treat to that 85 gray apex. And at our institution, we use ultrasound in the operating room to be 100% certain the plaque is right against the wall of the eye, exactly where it needs to be to center around the tumor. And this is what that looks like. That's actually a plaque sewn on a patient's eye. It has a gold back, so that's actual real gold that you're looking at. And then at the top image, that's what the tumor looks like. And then at the bottom right image, when I look at the screen, you'll see the ultrasound image with the plaque centered right around the tumor. And that's how we know that we've got perfect centration and excellent margins. But I want to talk about not how do we do the plaque today, but what are the things we do now that let you have the outstanding vision and anatomic results after the plaque? And to me, that single biggest advance has been the use of anti-VEGF therapy that can be injected in the eye called intravitreal injection. And the importance to understand is that the way that you determine an eye that needs to be treated is through that optical coherence tomography test. We and others have done multiple studies to show whether this treatment works. And in the treatment that was randomized, where half the patients got treated one way and half the patients got treated the other, we used the same drug. But in fact, what we did is changed how often we treated the patients. In one arm, you got injected every 6 weeks for the rest of your life. And in the other arm, we adjusted that injection where you may get injected at 4 weeks or 8 or 10 or 12 weeks, depending on how your eye was doing in response to the treatment. So that's called treat and adjust. So when patients came into our study, their vision was not excellent, but it was good. So the average vision was 20/80, and the retina was about twice normal in its thickness, what we call 500 microns of thickness, how thick the central retina was. And it's important that we all understand that this is a condition that goes on for the rest of your life. So long-term follow-up is very important to know that this treatment not only works at the start, but continues to work throughout. This is a 76-year-old gentleman. This is the color photograph of the right eye that was treated 11 months earlier with the iodine 125 plaque radiotherapy for a medium tumor that came right to the center part of the vision. And the patient came to me having noticed the vision was down for 6 weeks. Two things. If you have a sudden change in vision, don't wait for that time to occur. Don't wait for the 6 weeks. Come in earlier to your ocular oncologist. Make sure that your eye has a dilated fundus exam where your pupil is dilated, and make sure that you have images that should include OCT at every visit. So this patient's vision was 2400, and you can see to the right how thick the retina is, and to the left where the normal retina is. So on the right, you see extensive radiation retinopathy with swelling in the retina and a little dome of fluid under the retina. This patient was treated for 3 years, and vision went from 2400, which is legally blind, to 2030, which is legal to drive a car with. 2030 would be reading vision for most of our patients. And the retina thinned and normalized. It's not perfectly normal, but it is markedly improved. This is a 79-year-old gentleman. Now, this holds for children that get melanoma, which is fairly unusual, to very older adults in their 90s that get melanoma. So it doesn't matter what your age is. This can affect any age, any patient by sex, and even independent of race. It does appear this can be affected by other conditions that affect your blood vessels, like high blood pressure, hypertension, and diabetes, where diabetes can also damage the retinal vessels. So in this 79-year-old who has also diabetes, he was treated with the radiation plaque a year and 2 months ago, 14 months ago, and did very well. The tumor shrunk and it regressed. Again, this tumor goes to the macula, and he came in noticing a 5-week decrease in vision. You'll see all the yellow spots. That's called lipid. So when we look at the picture, we don't even need the OCT here to know that there is leakage that is likely affecting the vision. And the eye here, even with the leakage that's present, had a vision of 2100 plus or 2080 minus. And you can see that splitting, the black kind of tail, looking almost like a tadpole. That's the fluid in the retina called intraretinal edema. And this patient was treated for 3.5 years with injections every 6 weeks, and the vision recovered to 20/25. So again, a remarkable recovery of vision. Our third patient is a 54-year-old woman whose tumor is on the opposite side of the macula against the optic nerve. And in this case, she has both radiation retinopathy and radiation optic neuropathy that she noted occurring 8 months after. Now, the good news for this woman is she came in within 1 week of her symptoms. Her vision was still significantly affected at 2400, but she was able to be treated over 4.5 years every 6 to 9 weeks with injections, and her vision recovered to 20/30. So in the entire study, what we were able to do is look at the thickness of the retina on the OCT. That's called the central foveal thickness, and it's progressively normalized. So within 2 months, it was significantly better, and it continued to get better all the way through the first 2 years that we looked at that. The vision went from 20/80 to 20/62, so significantly improved vision. And overall, virtually 80% of the patients had vision better than 20/50. And that's that 20/40 or better vision that you need to be legal to drive in the United States. So that's an important level of vision. It usually means you're legal to drive, and it usually means with good lighting and the right glasses, you can actually read. Now, having said that, it was important in this study where we looked at, did you get injected every 6 weeks or did we adjust? Most patients needed to be injected often. So in the first year, the average number of injections was 9 injections per year. In the second year, it had dropped down to about 8 injections per year, and the third year down to 7 injections per year. But that still means you're getting injected around every 7 weeks within the third year from every 6 weeks in the first year. And it emphasizes how important the visit, the testing, and the treatment are. So in our study, the most common reason that our patients lost vision was that they were undertreated. So we really focused on how important it is to come back for your visit and to be seen regularly. And we've even encouraged patients that if there's a change in vision, even within a week of their visit, that they would call us and be seen early. It's not easy because many, if not most of my patients travel from a long distance, but it's important. So then the question becomes, did the treatment of these eyes, did it affect their tumors in any negative way? And the short answer is no. So it's interesting that the bevacizumab, which is the Avastin medication that we have used the most for our patients, was actually developed to treat melanoma outside of the eye in the colon. But it didn't do as well in that tissue as it actually seems to do in the eye. But remember, we're not injecting your eye to treat your tumor. Your tumor was treated with a radiation therapy. We're injecting your eye to maintain the vision and function of your eye. So all of our patients were alive and well. That's pretty remarkable. So we love that. No patient had metastatic disease during the trial. We know that you can get metastatic disease. We know that metastatic disease is often associated with the genetics of your tumor. Very important now for almost every center to focus on knowing the tumor genetics, and that requires a biopsy of the tumor itself. And your doctor should discuss that with you extensively. We do those biopsies routinely at the time of putting the radiation patch on the eye. So you don't have a biopsy and then your plaque radiotherapy. They're together. So you only have to go to the operating room that one time. Every tumor in this series was controlled. No patient got an infection from the injection. We worried about that at first, but that never happened. And only one patient had some inflammation in the eye. Interestingly, a very famous doctor had the inflammation, vision got very poor, but for us, fortunately, it recovered and we were able to go on and continue to inject him without that inflammation occurring again. So, radiation retinopathy is the most common reason that you lose vision when you're treated for a melanoma with a plaque or a charged particle beam of radiation. We know that anti-VEGF works for you. We know it's important to treat you early in the course of the condition and to treat you often. And it appears that that injection for your eye, it may do as well as the injection does for any of the other conditions that we manage, including macular degeneration and diabetic maculopathy. So from a patient focus, what's important? First of all, I think you need to understand that radiation retinopathy is very common. You need to know that it's easily missed without doing the OCT imaging study. OCT is the best to detect the problem, but it is also critically important that we follow the issue of your treatment with OCT to know, can we go shorter or longer between injections? And that is the adjustment period. When patients do poorly, it's because they were started on their treatment later than would be hoped for, and they were treated less often than was needed. An anti-VEGF, many of my patients come in and are specific about which drug to use for anti-VEGF therapy. From our experience, we've looked at 3 different drugs now, and they all have had very comparable benefits. So to us, it's not which of the anti-VEGFs your doctor injects you with, but that the doctor injects you and injects you often enough to control the retinopathy. And for the most part, know that that's often every 6 weeks. So I believe really in patient empowerment. I think you need, as a patient, to understand no one is going to be as focused as you are on really good care. Hopefully, your ocular oncologist will be at that level with you, but it's never wrong for you to be asking questions to better understand your eye. So I say, learn to look at the OCT with your ocular oncologist. In my office, it's up on a big screen, and my patients get very, very comfortable walking in, looking at the screen and knowing exactly whether they're better or they're worse. And I think that's really an important component of this. And I think it's also important to understand that you have to have that OCT over and over again, and you have to be able to compare. So in my office, we compare your OCT. We can look at any of the visits that you've had, but routinely we compare your last visit to today's visit, and we say better or worse or the same. If it's better, we may think to go a little longer between your injections, so go from 6 weeks to 7 weeks. If it's worse, we may want to go from 6 weeks to 5 weeks. And if it's the same, we may just stay right where we are. So look at your OCTs and have your doctor explain them to you till you understand them. Remember, you have to be healthy. We know that diabetes and hypertension affect your eye. We know you shouldn't be smoking because that damages the vessels in the eye, and it can make your radiation retinopathy and optic neuropathy worse. And the other thing is, remember, you can check your vision literally every day. And I tell my patients it's really simple. cover one eye, look at the fine print on the newspaper, cover the other eye. They should be comparable. Lines should be straight. You shouldn't have blurring or distortion of the letters or the lines in the eye. And if you do, you want your doctor to explain why that is. Hopefully, it's something simple like dry eye or eyelid disease, but you want a good answer for that. So, check one eye at a time, measure your vision every day, look at very small print, look at straight lines vertically and horizontally. And then when you're in your doctor's office, if you're not getting treated with an anti-VEGF, and if you've had radiation therapy, either plaque radiotherapy or charged particle, ask your doctor, what about anti-VEGF for me? Do I have any component of retinopathy? Is my eye showing any leakage or bleeding? Is my tumor showing any vascular activity? Those are the questions that you want to ask to know whether you should be treated with an anti-VEGF therapy or not. So for me, for my talk, what I'm interested in with you is knowing that you have the opportunity to do well. So when I started, and I've been doing this for a long time, when I started, the most common treatment when I came to Bascom Palmer was to have an eye removed. And that changed almost immediately so that we could keep eyes using radiation therapy, in our case, using the plaque radiotherapy. And then we focused very, very strongly on, okay, well, we've treated the eye, the cancer's not active, the tumor's controlled. How do we do better for our patients with vision? And that's what led us to the anti-VEGF therapies. And we have been interested in vision, as many ocular oncologists have, for decades with our patients. And the most interesting thing now is we're starting to look at alternatives that allow us to treat tumors without radiation therapy and still keep the eye, so that maybe we can limit the complications of the treatment itself. So I'm Dr. Timothy Murray. I'm coming to you from the Miami Ocular Oncology Institute in Miami, Florida, and thank you for allowing me the pleasure to talk with you today.
Terrific. Well, good morning, everybody. Thank you for having me. This is Armin Afshar from UCSF in San Francisco. Delighted to be speaking to you today. So, I also watched Dr. Murray's presentation along with you, and I do see that we have some questions here, which I'm delighted to answer first. So, the first question that I see here from Kirsten L., it says, if the tumor has a cavitary feature, does that mean it's always a ciliary body melanoma, and does it impact the radiation damage? So it's a great question. Now, when referring to whether the tumor is in the ciliary body or not, the parts of the eye that can be involved with an intraocular melanoma basically can be the iris, the colored part in the middle. The ciliary body, for those that don't know, it is the muscle that is behind the iris, behind the colored part in the middle of your eye. So my irises are brown. And that ciliary body goes around 360 degrees. And the choroid, if you've heard you have a choroidal melanoma, the choroid is the back layer underneath the retina in the back part. Melanomas can arise in any of those tissues. Some people just have an iris melanoma. Some people just have a ciliary body melanoma. Others have a choroidal melanoma. Sometimes your melanoma can be in more than one part of the eye, so it can be ciliary body and choroid, or ciliary body and iris. So really, to be able to determine if your tumor involves a ciliary body, often the best way to determine that is with an ultrasound, because as an ophthalmologist, we can't always see the ciliary body. It's tucked away behind the iris. And so to answer your question, Kirsten, having a cavitary feature doesn't always mean that it's a ciliary body melanoma. And whether or not the ciliary body is involved, the best way is to determine with an ultrasound. That kind of ultrasound is called ultrasound biomicroscopy, or UBM. So a UBM ultrasound can tell if it's involving ciliary body or not. Now, with regards to radiation damage, as Dr. Murray had pointed out, Really, the radiation damage is influenced by exactly where in the eye the radiation is going, so where your tumor is. And of course, that's different for every patient. In addition, the radiation damage is impacted by where your tumor is in relation to the critical structures for vision. So tumors that are in the back of the eye, close to the optic nerve, definitely there can be radiation damage to the optic nerve, and that's called radiation optic neuropathy. In addition, tumors that are in the back of the eye that are near the center of the retina, called the macula, have higher chances of having macular damage or radiation impact, and that's called radiation maculopathy. Uh, Tumors that involve the iris, the colored part in the middle of the eye, or the ciliary body, which is just adjacent to it, the radiation damage in those cases can often accelerate the formation of a cataract, which means the lens in the middle of the eye can become cloudy prematurely. And so all those things can play an impact in radiation change. So I hope that's helped answer your question. Now, moving along, I see that Nancy Beery has asked a question here. How long do you recommend to continue anti-VEGF injections if there's a plateau in vision after brachytherapy, i.e. visual acuity is hand motioned? This is an excellent question. So um, really, what I wanted to let you know is basically, we've looked, our center and many others have looked at visual acuity and outcomes after radiation, both with plaque brachytherapy and proton beam radiation. And really, one of the biggest predictors for visual acuity after therapy is, first off, what is the vision, what is the acuity to start with previous to radiotherapy? So that's one thing to keep in mind. So we know that eyes that have poor vision, eyes that are legally blind, meaning 2200 on the chart, which is the big E on the eye chart, or worse, those are eyes that are at higher risk for having poor vision even after radiation treatment. So that's one thing off the bat. Now, the second thing to keep in mind is basically anti-VEGF injections can help to curb swelling in the retina, radiation, blood vessel changes, and things. That being said, if your tumor is right adjacent to either the optic nerve or it's involving the macula, the center of the retina, or both, there is going to be some radiation collateral damage to those structures. So if the optic nerve suffers from having had radiation because the radiation had to go there because the tumor was there, or if the central retina suffers what's called atrophy. Basically, if your tumor involves the central part of the retina, the radiation can effectively kill the tumor, but also the retinal cells will suffer what's called atrophy or thinning. And it is important to keep in mind that anti-VEGF injections are not able to restore vision loss from atrophy or radiation damage to those retinal cells. In addition, anti-VEGF injections are not able to save vision that results from optic neuropathy or the optic nerve suffering radiation damage. So what I would recommend in this situation is it's helpful to speak with your ophthalmologist. Anti-VEGF can certainly be helpful at reducing swelling and reducing the odds of further vision loss. And so in a situation like this, if the vision's already hand motions or it's legally blind, it is a good question to pose to your physician, what are the goals of treatment? Is it to prevent additional vision loss? Is it to treat swelling, and to go from there? So moving along, I see that Jean Bassert has also asked a wonderful question here. If you have very low vision before radiation, what is the benefit of anti-VEGF after radiation? So this is an excellent question. So this again kind of hits on the point that I was mentioning, which is one of the most important predictors for visual acuity after radiation therapy is where your vision is to start before treatment. And so if vision is very limited prior to radiation, which can be due to a number of factors, including if your tumor is involving the center of the retina or is adjacent to the optic nerve, the benefits of anti-VEGF after radiation can be, it can potentially increase the odds of preventing even more vision loss, and also it may increase the odds of being able to preserve the eye, meaning that the eye can be maintained and not need to go on to have an enucleation. Now, one thing to keep in mind is in the presentation that Dr. Murray showed, which was wonderful and had some excellent images of patients who've done very well, those patients looked like many of them had medium-sized tumors in terms of thickness and diameter. Basically, the larger your tumor is, the thicker it is, the more radiation will be needed, and the higher the odds that the eye can suffer complications such as increase in retinal detachment, leakage of fluid from the tumor, and things like neovascular glaucoma and other complications. And so if you look at patients who, and it's a small minority of patients that need to have their eye removed or have an enucleation after having had radiation, the largest risk factors tend to be tumors with a very large basal diameter and tumors that are quite thick. And so keeping that in mind, if you're in that situation and you've had radiation either with plaque or proton beam, the benefits of anti-VEGF treatment, even though it may not improve your vision much, may be number one, to prevent further vision degradation or further vision loss, and so to help you keep the vision that you have. And number two, it can help hopefully prevent additional complications such as neovascular glaucoma, or essentially worsening of vision and other complications that could lead to the eye becoming blind and painful. These are all excellent questions. So moving along, I see from DS, it says, any reasons to have the injection every 4 weeks? So I'll start with that question first. The reason that many of these injections are given on a 4-week basis is any of the injections that are given into the eye, and you may hear names like Avastin, Lucentis, Eylea. These medications are actually metabolized by the body, and so the medication breaks down over some time and is cleared. And so the amount of time that medication can last in the eye is anywhere between about 4 and 6 weeks for Avastin and Lucentis. The medication Eylea or aflibercept is thought to last a little bit longer, maybe up to 2 months. And so the rationale for giving the injection every 4 weeks can be that you want to give the medication basically in time so that the eye has some medication on board after it's cleared from the body. Now, just to let you be aware, these medications are extremely common in ophthalmology, and we use them for a variety of retinal disorders, including vein occlusions, diabetic retinal swelling, and age-related macular degeneration. And for those conditions, we often do give them injections every 4 weeks or so. If your physician feels that a 4-week interval is more appropriate, that certainly is fine and within the standard of care. Now, with the question about the next part of this question says, what about pain during and after the injection? Any advice, any changes in drugs, etc.? This is an excellent question that basically we all experience as retinal specialists and ocular oncologists, and we fully recognize that being on the receiving end of the injections can have varying levels of discomfort. So a couple of things off the bat. So with regards to discomfort during the procedure, most ophthalmologists do these injections in a pretty standardized manner. There is some form of anesthetic that's given, usually initially topically in the form of anesthetic eye drops. That's the first step. Then the next is to place some topical. Some ophthalmologists will use a Q-tip that's saturated in lidocaine to apply to the surface of the eye for several minutes. I personally actually give a little bit of extra lidocaine. I give an injection underneath the conjunctiva for additional anesthesia effect. Ideally, so with the subconjunctival lidocaine that I administer, the extra lidocaine injection, patients actually don't feel the injection itself. They may feel a little bit of pressure, but they don't actually feel any pain for the injection. The most common reason for pain during and after the injection is really from the preparation that's used to sterilize the eye. Now, betadine solution, which is essentially iodine, is utilized for these injections. It's really the same kind of preparation that we do for intraocular surgery in the operating room. And the reason why this iodine is used is the rates of infections after these injections when using the iodine betadine prep is around 1 in 2,000, which is really quite low. I've been performing thousands and thousands of these injections over over 10 years, and I've actually not had a situation where somebody's had an infection, knock on wood. And the reason is that we use this iodine betadine solution. There are other studies that have looked at the use of different preparations like chlorhexidine and other things in situations where patients may have an iodine allergy. And bar none, every study has shown that when you don't use that betadine iodine solution, the risk of infection after these injections is much higher. So we know that it works. Now, the negative, though, is, betadine stings. If you pour iodine in a fresh cut, as many people might know, it can be extremely uncomfortable and it can sting. And in the same way, when you're applying it to the surface of the eye, it can be uncomfortable as well. So in some situations, it may be appropriate. It is actually possible to dilute the betadine prep with saline, and that can sometimes help with some of the irritation the patients face. Also, what I find to be honestly most beneficial is I spend a lot of time irrigating or flushing the eye surface out after the injection with sterile eye wash, and that can help significantly with discomfort. Other things, some patients may find it helpful to take some Tylenol after their procedure, and that can help a little bit as well. Great. Moving on, I see another question here. It says, my doctor, this is from Kirsten L. My doctor stopped injection due to inflammation. Should I try it again? My doctor is nervous. My current only problem is bleeding, but lasering has stopped it. It's a good question. I did want to point out that in addition to the medications that Dr. Murray has mentioned, so I do utilize Avastin and Eylea, aflibercept most commonly. Those are anti-VEGF drugs. I do actually also utilize Ozurdex, which is a dexamethasone ocular implant. It's basically a steroid implant that's the size of a grain of rice that's injected into the eye in the same way as an anti-VEGF injection. That implant can last anywhere between 3 to 6 months. And I do find that in addition to anti-VEGF, in patients who have recalcitrant bad swelling or inflammation inside of the eye, it can really help to treat radiation retinopathy and make the eye more calm. So every situation is a little bit different. What I would suggest is in a situation where there's inflammation in the eye, you may want to speak to your doctor in terms of what might be causing it and whether there may be any role in any intraocular steroid treatments. Next question I see here from Chantal Feinberg is, what is the difference in the terms choroidal and uveal? And that's an excellent question. So the uvea refers to all three pigmented tissues inside of the eye. So the uvea includes the iris, the colored part in the middle of your eye. Mine is brown. The ciliary body, so the iris, the ciliary body, and the choroid together makes up the uvea. The uvea is basically contiguous. This is a pigmented layer that includes the iris, the colored part of your eye, the ciliary body, which is the muscle that is on the back side of the iris, and the choroid, which is the tissue that is underneath the retina in the back of the eye. So sometimes the terms are used interchangeably, but just be aware that the choroid is the tissue that's specifically under the retina. The uvea is the choroid plus the iris plus the ciliary body. Moving along, I see that Janet Archer has a question here. My tumor surrounded the optic nerve, and I'm getting Lucentis every 2 months, but my vision is almost completely gone. Should I continue the injections? Excellent question. So as we mentioned earlier, unfortunately, when your tumor is around the optic nerve or near the optic nerve, no matter what form of radiation you use, whether it's proton beam or whether it is plaque, there's going to be some collateral damage, radiation damage to the optic nerve. And so that likely explains why the vision is suffered. Now, whether or not to continue the injections is an excellent question. There are still potentially benefits from anti-VEGF injections. So in a situation like yours, it can help prevent the onset of neovascular glaucoma. So that's high fluid pressure in the eye. It can also treat swelling in the retina. And so there certainly may be benefits above and beyond just trying to restore vision in that scenario. So it is worth having a discussion with your ophthalmologist who's giving you the injections. I would suspect that the reason that that's being continued for you is because it increases the chances of avoiding additional complications. Now I see that Nancy Beery has a great question here. Can anti-VEGF injections cause cataracts? And if so, it is important to undergo cataract surgery. That's a terrific question. So, as far as we know, anti-VEGF injections shouldn't actually cause cataracts. The cataract refers to the lens in the center of the eye. The injections are not given basically into the lens, but they're given into the vitreous jelly that's in front of the retina. Rarely, if there's some kind of a complication where the needle that's used to give the injection, if that somehow bumps into the lens, that can accelerate cataract. But otherwise, we give these injections very routinely, and they don't typically have any bearing on cataracts. Whether or not to undergo cataract surgery is a discussion that you are free to have with your ophthalmologist. And really, it's a great, well-tolerated procedure. And whether or not you have injections or not shouldn't have a bearing on whether or not you can have cataract surgery. I see a question from John Dagres. Are there differences in the 3 major anti-VEGF medications other than cost? This is an excellent question, and it comes up actually for other conditions that we treat using anti-VEGF. So the 3 medications that we're referring to, these anti-VEGF meds, are Avastin, the generic name is bevacizumab; Lucentis, the generic name is ranibizumab; and Eylea, and that's aflibercept. There are some differences in the actual molecules themselves. As Dr. Murray had mentioned in this presentation, I believe Avastin or bevacizumab was originally developed as a colorectal cancer drug, chemotherapy agent. That medication was not developed specifically for use in the eye. And so for that reason, it's used in ophthalmology as an off-label product. That being said, we have extensive experience in the field using it for nearly 20 years. Lucentis and Eylea, these are medications that were formulated specifically for use inside of the eye. Now, the main difference with Eylea, if you look at the packaging instructions and the indications, there's potentially a longer half-life of Eylea. Potentially it might last longer inside of the eye. Typically for most ocular conditions for which there's approval from insurances, most often we'll start with Avastin because it is off-label and it is the least expensive. If there isn't as much of a therapeutic response, then you might potentially try Eylea. I personally utilize combination therapy, so I do find that there's also often after radiation an inflammatory component in addition to a VEGF drive inside of the eye. So I do typically also offer steroid medication in the form of Ozurdex, which is an intravitreal implant of steroid medicine. I do find that often the Ozurdex and the anti-VEGF can be synergistic and can boost the response. Moving on, I see Brian Combs has a question here. It says, I've had Eylea treatment for the past 5 years after plaque radiation for a large ocular melanoma. Shortly after radiation, I had a retinal detachment that was repaired and developed glaucoma in the eye. I do have pain intermittently between Eylea treatments that's pretty sharp in the eye, along with a baseline irritated, scratchy feeling. Any remedies for this? So, sorry to hear all that you've been through. So, just to let you know, when you have sharp pain, scratchy, irritated feeling, that often points to an issue on the surface of the eye, corneal issue. Certainly having had radiation of any form can exacerbate that problem. So it may be worth speaking with your ophthalmologist to see if there's any role for seeing an ocular surface specialist or a corneal specialist. They may have additional interventions or things they can do to boost and improve the ocular surface, the health of the cornea, and that may hopefully help with some of the irritation and scratchy sensation that you have. Great. Well, we do have some time left here, so I've enjoyed speaking and answering some of these questions here, and want to get to a little bit more. So, essentially, when I was asked to speak today, Dr. Murray was to speak more on plaque, and I was going to speak on proton therapy in terms of what to expect after treatment. The reason that I didn't want to actually prepare set slides is that there's a lot of overlap. So, with radiation treatment, basically, as a principle, you're basically radiating your tumor and you're killing the tumor in that way. And what happens is, as the tumor cells start to die, you can have swelling in the retina. Basically, these tumors can release various hormones, including vascular endothelial growth factor or VEGF. The radiation itself can induce inflammatory changes in the eye. And this is the reason why various interventions such as VEGF injections, steroid injections can be helpful in curbing some of the radiation side effects. So As mentioned before, in terms of expectations for how vision will end up after treatment, one of the largest predictors is how the vision was before treatment. The second most important predictor for how your visual acuity will be is basically where in the eye the tumor is located. So tumors that are located near the optic nerve or in the on the macula, certainly there can be collateral radiation damage from that. And last but not least, I also want to underscore Dr. Murray's excellent point that really there is a lot of maintenance that's required after radiation. Essentially, these injections, anti-VEGF injections, steroid injections are really a long-term commitment. But we do know that with continued administration over time, it helps to kind of calm the fire from the radiated tumor and get the vision as good as it can possibly be for you. Now, another thing that I want to talk about, because we only have a brief amount of time left, is a topic that's very near and dear to my heart and that's very important to me to discuss, which is not just how your eye does and what to expect after radiation, but really just the toll that this diagnosis and all of these treatments can have on your mental health. So one thing I let patients know is, when they're having surgery to have the plaque placed or the tantalum markers placed for radiation, and as they're undergoing their treatment, really, as physicians, we can get you through the initial treatment. We can tell you what to expect in terms of, the appearance of the eye and what to expect in terms of vision. But what's not addressed as much is the toll that all this can take on your mental health, your well-being. There's a lot of just exhaustion from going through the stress of all the visits and all the injections and things. And so wanted to let you know that it's completely normal to be tired during all this and to have anxieties and really there's a lot of ups and downs. So one thing that I certainly let all of my patients know is we do at UCSF refer our patients to psycho-oncology. Now, what this is, psycho-oncology, these are health psychologists that help cancer patients from all different kinds of cancer, and our associates help patients specifically with ocular melanoma. They help them cope with, this new stressful diagnosis and, all that's involved in treatment and care. And so did want to let you know that going through all this care pathway, as ophthalmologists, we do everything we can to basically eradicate the cancer and get your vision as good as it can be, but also don't want to neglect to let you know that mental health is extremely important, and would certainly recommend that if you're feeling stressed or anxious, this is a completely normal thing undergoing this situation, and that a health psychologist can be very beneficial in talking through things and providing support. So I think that's all the time that we have, I'm told. So I really want to thank you all for your attention and for your time. It's always a pleasure speaking at this meeting. You guys are the reason that we do what we do, and we're grateful and blessed to be able to care for you. So thanks again, and have a wonderful rest of the meeting.
Thank you, Dr. Afshar. Your responses are thoughtful and helpful. I know that the OMI community is very grateful to have you. So thank you so much for joining us.